Welcome back to the deep dive, where we really get into the critical ethical tightropes, the professional dilemmas that define high-stakes medical practice. Today, we are deep diving into probably the toughest balancing act in healthcare.
I'd agree with that.
It's where your personal values, so religious, moral, political, they just hit this hard wall of your non-negotiable professional duty to the patient.
Yeah.
And look, this is not just academic. For anyone facing the situational judgment test, the SJT, or, just starting out, this is a huge area of professional risk.
A massive one.
So let's just set the scene right away. Imagine this. You're the only doctor on shift, maybe in a remote unit. A patient needs immediate, time-sensitive care, a transfusion, a specific procedure, something that conflicts directly with your most fundamental personal beliefs.
Right.
What is the one action that scores highest and keeps you, safest professionally?
Well, the answer is it's the absolute bedrock of good medical practice as the GMC defines it, and it's this. A doctor's personal beliefs must never, and I mean never, act as a barrier to a patient accessing appropriate, timely medical care.
Right.
That duty to the patient, their immediate needs, that is paramount, period.
And that right there, that's the mission for this deep dive, isn't it? We're not just, reading out GMC guidelines. We're trying to build a tactical framework for navigating this tension.
Exactly.
Because getting this wrong, either in a scenario or in real life, it can be a breach of your duties, a big one. Non-discrimination, fairness, it can lead to, significant professional trouble.
It really can. So let's start with that non-negotiable foundation. We are bound by the Equality Act 2010 and, of course, the core principles in the GMC guidance. We have to treat every single patient fairly. No discrimination, doesn't matter what their age is, disability, race, religion, sexual orientation, none of it.
But here's where the guidance goes a step further, and I think this is where so many people fall into a massive exam trap in the SJT.
Oh, yeah.
The sources point to paragraph 19, which is all about sort of patient culpability. It says, doctors must not refuse or delay treatment because they believe a patient's own actions or, their lifestyle choices contributed to their condition.
That is so critical. Whether the patient's condition is linked to smoking or drinking or, dangerous sports, even not following medical advice before,
right,
it is completely irrelevant to the care they need right now. The safest doctor, the one who scores highest, assesses the patient holistically, respects their history, sure, but ensures the treatment is based only on objective clinical judgment.
So your personal feelings about their choices, your frustration, it has to play zero part.
Zero. And if you feel like your judgment might be compromised, that's when you have to start the formal process of conscientious objection.
Which brings us to the nuance. Because doctors do have a right to opt out of certain procedures, but it comes with these huge, huge caveats.
Huge. You cannot discriminate, you can't harass, you absolutely can't deny appropriate care. This is the high-yield action plan. Think of it like 3 non-negotiable steps.
Okay.
First, you communicate gently. You tell the patient that you don't provide this procedure. And crucially, you have to be so careful not to imply judgment.
Right, the tone matters.
The tone is everything. Keep it professional, keep it patient-focused.
Yeah.
Second, you inform them of their right to options.
Yeah.
You tell them very clearly they have a right to discuss their condition and all the options, including the one you object to, with another doctor.
Okay, that makes sense.
And third, and this is the big one, ensure access and zero delay. You have to make sure the patient has all the information, all the practical help to see another professional immediately.
Immediately.
And if it's impractical for them to arrange it, then you or a colleague, you have to make those arrangements for them. And you do it without delay.
That third step, ensure access, that feels like the biggest practical hurdle, doesn't it? I mean, isn't that just pushing your work onto a busy colleague?
That's a great point, and it does highlight the professional burden. But the guidance sees it differently. Facilitating access isn't about your beliefs. It's about the institution's guarantee that the patient gets care.
I see.
Your right to object is protected, yes, but only if it doesn't infringe on the patient's right to health care. The burden of finding that colleague, it falls squarely on you, the objecting doctor.
Okay, so a memory hook here could be something like, think of your duty as an unblockable access path.
I like that.
Your objection can be a signpost, pointing them somewhere else, but it can never, ever be a roadblock.
Never a roadblock. I love that. And this duty becomes absolute in an emergency.
Right.
The guidance is crystal clear. In an emergency, you must not refuse treatment needed to save a life or prevent serious deterioration. even if it conflicts with your personal beliefs. If you're the only one there, you act.
The sources even give that really specific example of signing a cremation certificate.
Yeah, if you are the only doctor who can legally do it, you must do it, even if your faith objects.
Life preservation and public safety, they always take precedence.
Okay, so let's flip this. What happens when it's the patient's beliefs that conflict with the care you're recommending? This is where the scenarios get really messy.
They do. And we see about 3 common exam patterns here. First is the patient request based on beliefs. A classic one is male circumcision for religious reasons.
Okay.
The best action here is to discuss everything, the benefits, the risks, side effects. If you assess it to be of overall benefit to the patient, then you generally provide it, or you refer them appropriately. The big caveat, though, is when the patient is a child.
It's always about best interests then.
Always best interest.
So what if the parents disagree on treatment, or they're asking for something you think is not in the child's best interest?
Okay, so if it's non-essential, you can just decline based on your clinical judgment. But if parents can't agree on essential life-saving treatment, you have to advise them that you need to seek authorization from the court.
You can't let that disagreement harm the child.
Never. The second pattern is the competent patient refusal. This is a huge test of autonomy. The classic example, a competent adult Jehovah's Witness who refuses a life-saving blood transfusion.
Right.
Your best action is unwavering. You respect the decision. A competent adult can refuse treatment even if you think it's wrong or irrational.
Even if it will lead to their death.
Even then.
Yeah.
You advise them of the risks, clearly, but you must not pressure them. No coercion, no judgment. Overriding a competent refusal is a massive legal risk.
Which brings us to the third pattern, probably the highest stakes one. Parental refusal of essential treatment for a child.
If parents refuse essential treatment for a child who lacks capacity, you have to escalate, but very carefully.
Okay.
First, talk to them. Discuss their concerns, see if there are any alternative treatments you could agree on. Involve the child if they're old enough. But if, after all that, the treatment is essential to preserve life or prevent serious deterioration, and you still can't agree,
Then you have to act.
you immediately seek advice on approaching the court. Patient safety, specifically the child's best interests, it trumps parental autonomy when a life is on the line.
That is such a vital distinction for the exam, the competent adult versus seeking court authority for a child. Okay, let's wrap up with the trap answers. The things that seem reasonable but score terribly.
Right. Trap number 1 is judgment. Expressing personal disgust, judging their lifestyle, refusing to treat them because you disapprove of how they got sick.
You're their doctor, not their moral critic.
Exactly. You violate your duty to treat based on clinical need.
No.
Trap 2 is ignoring or abandoning the patient. Just saying, I object, good luck, and walking away.
That's a definite fail.
A definite fail. Your duty requires you to actively arrange alternative care without delay.
And what about imposing your own beliefs? That seems more subtle.
That's trap 3. Discussing your own beliefs with a patient when they haven't asked. It's a breach of professional boundaries. The rule is you can only discuss your beliefs if the patient asks you directly or they indicate they'd welcome it.
And it has to be relevant to their care.
Always. You're their doctor, not their spiritual guide. And finally, trap 4. Delay.
Ah, the classic SJT trap.
It is. Telling the patient to wait a week for another colleague, putting off the referral. Patient vulnerability and time sensitivity demand you act now. Delay is just another form of obstruction.
That's such a clear summary. The focus is always on actionable steps, not just what you believe internally. So to summarize everything for revision, 3 key points.
1. Patient access to appropriate, timely care always outweighs a doctor's personal objection, especially in emergencies. 2. If you do object, you must immediately facilitate a referral. You have to actively ensure the patient sees someone else. No obstruction, no delay.
Got it. And 3.
And 3. Respect a competent adult's refusal of treatment, absolutely. But be prepared to seek court advice if parents are refusing life-saving treatment for a child.
The sources ground all this in the Human Rights Act, which gives us freedom of thought and conscience. But here's the crucial footnote, isn't it?
It is.
That right can be qualified. It can't be used to support an action that infringes on the rights and freedoms of others. In this case, the patient's absolute right to access healthcare.
That's the whole thing in a nutshell.
And that complex boundary, it isn't just theory, it's the true test of professional responsibility. Good luck with your revision, you.